Today we will be talking about COVID's impact on maternal health in low-income areas. My name is Jasmine, and I'm a sophomore at Saratoga High School, which is in the Bay Area. At school, I'm the chapter lead of our Dear Asian Youth Club and a math tutor for my local tutoring nonprofit. I hope to pursue public health in college, and I'm deciding between becoming a professor or an OBGYN. Now let's get into why this topic is global health related. COVID has quite literally affected the entire world's population, and 10% of the female population aged 15 to 44 are pregnant. This statistic gets bigger or smaller based on how developed a country is, with worse obstetrical outcomes or worse birth outcomes for those who are in developing or poor areas. That, along with the pandemic that has caused the majority of the world's hospitals to be at full capacity for months on end, and the global decrease of employed people and average income, has made it harder to find a safe place to give birth or even pay for necessary pre- and postnatal checkups. And that results in a higher risk of preventable pregnancy complications globally. Pregnant people are also more susceptible to worse and more detrimental COVID symptoms, and this is an issue that intersects global populations, marginalized groups, and medicine, effectively making it global health related. And let's talk about specifically why we should care. According to World Vision, 1.9 people live in extreme poverty. These are the communities who have limited to no access to healthcare or hospitals during the pandemic, despite having some of the highest rates of pregnancy. This means that hundreds of millions of pregnant people, the people who quite literally have the future in their hands, do not have access to healthcare. Poor people, specifically poor women, deal with the intersection of sexism and classism, which causes so much trauma that is only worse with the introduction of an entirely new disease and living condition. This pandemic doesn't affect everyone equally, and we need to address that. And let's also go over some background information just so this whole presentation is less confusing. I'm sure you all know what the COVID-19 pandemic is, but in case you didn't know, it started through a highly infectious novel strain of virus called SARS-CoV-2 that was found in China, and it infected to people, and it spread throughout the world through travel and airborne contact. This resulted in overflowing hospitals, stay-at-home orders, and economic crashes. And when I say intrauterine, I mean within or of the uterus. So for example, intrauterine transmission involves something being transported from the parent through the uterus and to the baby. Disproportionate means unequal among populations and demographics. Pre- or postnatal means before or after labor and delivery. So for example, pre-postnatal care, you'll hear a lot throughout this presentation. And an LMIC is a low or middle income country. Now let's get into the direct effects of COVID on low income maternal health. Pregnancy-related immunologic changes make people more susceptible to respiratory diseases. And there's this really interesting October 2020 analysis of 400,000 American female patients that found that pregnant women were between 2 to 3 times more likely to be admitted to the ICU than non-pregnant women. And let's look at this table. So first of all, 23K of the 400,000 were pregnant, 386K of the people in the study were non-pregnant, and out of all that 400,000 people, 1,700 about were symptomatic with COVID. 245 of those people were admitted to the ICU, and 1,492 of those non-pregnant people were admitted to the ICU. And if we do the math, so for example, 245 divided by 23K, we see that 1% of pregnant women were admitted to the ICU, while only about 0.39% of non-pregnant women were admitted to the ICU, which explains this statistic right here. And globally, so outside of the US, there is this also very interesting study done in Bangladesh, Nigeria, and South Africa, which are all LMICs regarding the utilization of natal care and its effects on maternal and child health during the pandemic. So we see here all the countries divided into 3 little tables. And if you don't know what ANC is, that's antenatal care, so that's ultrasounds, blood tests to assess and protect fetal and maternal health. Family planning clinics is things like abortion, contraceptives. Child vaccination is, very self-explanatory, bringing your kid to the pediatrician to get their measles or flu shot. And in Bangladesh, we saw a 69.1% decrease in these 3 procedures overall, with no one going to family planning clinics between April 2020 and April 2019. And in Nigeria, we saw a 55% decrease. And in South Africa, unfortunately, that average is not available because hospitals in South Africa did not supply enough information to conclude the increase or decrease in family planning clinic attendance or child vaccination attendance. Now let's get into the indirect effects. And I'm going to format this in a cause and effect kind of way, and you'll see how that works right about now. Okay, so some direct effects include closing borders, reducing public transit, and shelter-in-place orders just to reduce airborne transmission. And because of that, we see loss of income, people getting laid off, skyrocketing prices that push already impoverished people into increased financial turmoil, meaning that these already impoverished pregnant people will have strained access to highly important resources such as food, utilities like heating, water, which become all the more important when you're not only caring for yourself, but caring for a fetus. And another direct effect are quarantines and stay-at-home orders, which are imposed to protect people's health. And because couples are, cooped up inside together, we have seen spikes in domestic violence, which puts stress on the parent carrying the baby, stress from lack of contact with the outside world, and mental health issues caused by fear of transmitting COVID through the uterus. And then the last direct effect is hospitals are overcrowded, and therefore patients must be turned away and non-essential medical care must be postponed. And we have seen anecdotes in LMICs where this has negatively affected maternal health. So in Nigeria, hospitals were forced to stop accepting patients entirely to reduce risk of wide-scale doctor-to-patient transmission. And naturally, this affected maternal populations and did not allow them to have a clean, safe, and comfortable place to give birth. And in India, we saw steep declines in facility-based births, and specifically we saw 2 cases of women in labor being turned away, with one of them going to 8 hospitals before passing away from the sheer stress on her body. And there was this really interesting graph that I saw via Health Policy Plus, and it's about the statistical projection of indirectly caused maternal and child deaths in various LMICs. And you can just look at that and see that in total, about 1 million maternal and child deaths will occur just simply due to not using maternal services during COVID. And let's just conclude. First, I'm going to summarize this information. So pregnant people in the US are 2 times more likely to get admitted to the ICU for COVID. Thousands of indirectly caused maternal deaths will occur in Nigeria, and Bangladesh saw a 69% average decrease in maternal care utilization. And let's talk about what this means. Globally, COVID has been dealt with by a one-size-fits-all approach that causes global disparities because we don't consider socioeconomic and political factors to formulate appropriate pandemic responses. And let's also talk about limitations. So for example, you saw in South Africa, we were not able to find an average decrease or increase in maternal care services because studies are done based on voluntary COVID reports that hospitals may submit to the CDC. And pregnancy status in the US is missing for 64.5% of female COVID cases. And data on severe outcomes is measured by patient surveillance, which is entirely subjective and may be biased one way or another. I'd like to give a big thank you to the GHLC team at Johns Hopkins for making this possible, as well as the people listening to this at home. The GHLC has taught me so much about global and public health and reminded me as to why I'm pursuing it in the first place. Also, thank you to the researchers who made collecting this information possible in the first place. And here's my references. And again, thank you for listening. If you have any questions, please email me or contact me via social media. And I hopefully look forward to seeing you again next year and speaking at this amazing conference. Thank you so much.